Very briefly, while the guy's doing what he needs to do, there is a connection with me and Ringer, apart from him also being at University College London, but about 100 years before me. The contaminated water was actually tap water. His technician was lazy and didn't make distilled water as told, but used tap water. And the tap water came from the New River. So the New River was built in 1613 to bring water into London from north of London for the expanding population. Why am I telling you this? Oh, thank you very much. Why am I telling you this? Well, I was born literally a stone's throw from the New River, and I was brought up also about 2 stones throw from the New River. So I was brought up drinking Ringer's solution. So I'm a very balanced individual. Ho, ho, ho. Okay. Can I ask a question? Do you mind if I ask a show of hands? Who agrees with Matty before I basically convert you to my argument? Who agrees? Very slow. Okay, it's about half of you. Okay. So I need to win you over.
What number are you talking about? 8 or 12?
Oh, 8 or 12. Okay, 8. Less than 8? There's a few hands. Less than 10? Less than 12? Okay, so let's be seen. Who knows? I'll tell you. Nah. Okay, declaration of interest. Nothing to declare except Matty's wrong. Okay, so we all know that hyponatremia in itself is potentially dangerous. Seizures, coma, cerebral edema, etc. And the brain takes longer to adapt. Oh, sorry. The brain that's had chronic hyponatremia has had some chance to adapt, and that's the argument that for acute hyponatremia you can be a bit more aggressive. Oh, like history. Yeah, this is the first description I'm aware of in man, not rats, and this was in 2 cases: alcoholic, malnourished, deaf. And there were 3 cases, and none of them was a low sodium described. And again, this is a series, so the old term is CPM, but it's known to be extrapontine as well, so osmotic demyelination syndrome. But this is 38 case series, 541 patients. You only had severe hyponatremia in about half the patients, and normonatremia in a quarter. There was a lot of alcoholics, liver disease, malnourishment, and the outcomes: half made a good recovery, death in a quarter, disability in about a quarter. And there you are there. Okay, the mantra. Rapid or overcorrection of plasma sodium is a risk factor. Correction must be performed slowly in patients with chronic hyponatremia, and chronic is arbitrarily defined as more than 48 hours duration, not 47. Correction can be more aggressive with acute hyponatremia. So that's what we're taught, and I got into this. I do some stuff in the National Health Service if patients are sued, and they get sometimes expert views or inexpert views, and you often get cases of osmotic demyelination syndrome. The doctors did bad by poisoning the patients with too much or too quick sodium replacement. So it made me look at the literature, and it's quite interesting. So when you look at the guidelines, and Matty actually made the point, it's a wonderful model of inconsistency reflecting the weak evidence base. 0 randomized controlled trials, and when you read the guidelines, these people don't actually follow the evidence. This was a nice review of the reviews, a review of the guidelines in 2014. They found 10 guideline documents, 5 were clinical practice, 5 consensus statements. 8 advocated hypertonic saline if the patient's symptomatic, very symptomatic, acute onset. 8 recommended limits for speed of increase, so 2 didn't. These varied between 8 and 12 millimoles per 24 hours, and there were inconsistencies in the recommended dose of saline, the initial infusion speed, and what else to do afterwards. So basically, they made the point that it's a real mess, There's many of them vary in methodological rigor, and they're inconsistent. And so a general view, but if the patient's severely symptomatic, they're fitting, you can give them some hypertonic saline to raise it by 5 and hopefully stop them fitting. People generally think the risk from the hyponatremia is less if the sodium's above 120. The question is how quick and what else do you do? And I'm not going to go through all of this, but obviously depending on the cause and the type of hyponatremia, whether they're fluid deplete or not. And, going back one. But again, it's very inconsistent. Less than 6, less than 8, less than 18 in 24 hours. Let's look at some stuff. IAS, Matty mentioned IAS, he's written a lot on this, and I'm going to come back to him at the very end. So this is a nice study. Women are more likely, post-menopause, women are more likely to be affected, and it's probably hormonal pre than not. So there's much higher risk in post-menopause in women, they found. And here, this was chronic symptomatic hyponatremia. The average sodium was 111, present for 5 days, and you see there was a high complication rate. But the outcomes did not correlate with either the initial plasma sodium level or the rate of correction. So if we take 120 below, 1 corresponds to full recovery, 4 is vegetative, 5 is death. So the left-hand column and the 2 right-hand columns. And you can see that there's no good relationship, is there, with the initial level and at the bottom, the rate of correction. So I've picked an arbitrary 8 millimoles per litre correction in the first 24 hours. And you can see here, with the recovery, there were a lot of patients who made a full recovery despite a much more aggressive rate of correction. And despite having very slow correction, a lot of people ended up vegetative or dying. Here's another review of the literature. They found 166 cases of osmotic demyelination syndrome related to hyponatremia, 158 of which reported the correction rates. The mean presenting sodium was 111, and the correction rate was 19 millimoles in the first 24 hours. That was the average correction rate. And what did they find? Essentially, they did a cutoff of above and below 12 millimoles in the first 24 hours. And you can see no difference in complete recovery, partial recovery, no recovery, or death. Didn't make any difference. But I do agree with Matty. Perhaps too much of a good thing is bad. And perhaps it's not the rapidity, but the level if you overshoot. So this is a study where they looked at 13 patients who developed or didn't develop central pontine myelinolysis, and they did MRI, and they found 3 did develop it, 10 didn't. If you look at the 10 that didn't develop it, the rate of correction was on average a mean value of 0.74, so that's about 20 millimoles on average, going from 105 to 123. The 3 that did, it was more aggressive, 1.25, so that's about 30 millimoles in 24 hours, so that is quite a big jump. But let's come forward to the more modern era. Matty skillfully avoided more modern data. And now we have databases. Wow, and people plug into databases. This is from a group in the States. They looked at, in their hospital group, 1,490 patients with a sodium below 120. And they found 41% were corrected more than 8 in 24 hours, 12% more than 18 in 48 hours. Only 9.6% developed osmotic demyelination syndrome, and one already had it on arrival in hospital, so before they were poisoned with too much sodium. And of the 8 who had it, 4 had correction rates below or within that 10 to 12 millimole guideline recommended by US and European guidelines, recommendations. More modern. So this is New England Journal of Medicine evidence. This is a multi-center retrospective study from 5 Toronto hospitals. So over a 10-year period, they identified nearly 23,000 patients who presented with a sodium below 130. The mean sodium overall was 125, but about 12% had levels 110 to 119, and a further 1.2% below 110. There was rapid correction, we'll talk about that in a second, in 18% of the patients. So 2,476 between 8 and 12, and 1,156 over 12. So these are big numbers. Only 12.05% developed osmotic demyelination syndrome, 7 of whom did not have rapid correction of sodium. And what they showed there, so the bottom line shows the osmotic demyelination syndrome. From their database, they didn't know how many of the 5 who was over 8 fell into the 8 to 12 or over 12, but 5 versus 7. But if you look there, interestingly, mortality, death in hospital, was a lot higher in those with slow correction. Discharged to supportive care, so they didn't die in hospital, but they had some problem, was higher. Why? Maybe it's the underlying cause that brought them in. Matty showed the data that actually the people with lower values actually do better. So it might be something about the patient, they didn't look into that. But they concluded limiting the sodium correction rate was associated with higher mortality and a longer length of stay. Whether it influences neurological complication needs further evaluation. I'll finish here with this study. Just come out. They must have known we were going to have this debate. So it's me and the New England Journal of Medicine against Matty. Multi-center study from Boston, 1993 to 2018. 3,274 patients with a sodium on presentation below 120. 38% did it really slowly, 29% between 6 and 10, 33% above 10. Only 7 developed osmotic demyelination syndrome, 5 with slow rates. And if you look, the sodium, depending on the correction, was fairly similar in all these 3 groups. And the average sodium correction, really slow, 3 versus 8 versus 16. 16, plus or minus 6. But look at the mortality. Again, it was a lot higher when you did it slowly. 13% versus 5% when you were more aggressive. 30-day mortality, 21% versus 8%. And they did lots and lots of univariate, multivariable modeling, propensity score weighted analysis, and basically the same message came out. If you took as a reference 6 to 10, you were much more likely to die if you did it slowly, and much more likely to survive if you did it quickly. And the admission serum sodium had no impact. So, mortality, again, another big study, observational, retrospective, but higher with a slower correction rate. So, with Daniel Hoffmanner, we wrote, well, basically picked on 4 dogmas in the literature, you know, DKA, etc., heparin thromboprophylaxis, and we picked on sodium and went through the literature at the time, so we didn't have the New England Journal of Medicine evidence with those 2 studies published before then. But basically we made the point that all the recent studies with more moderate correction rates, so in other words below 20 millimoles in the first 24 hours, did not show a relationship with poor outcomes. It's an uncommon event. A slower correction rate maybe could be applied if there are multiple risk factors. The patient's an alcoholic and they're malnourished, etc., etc. We should, and you know, I don't know how many of you see an endocrinologist on your unit. Ever? Yeah, so they pronounce, oh, you should do it slowly, but it's bloody difficult, isn't it, to try and really control the sodium. You know, there's lots of swings and roundabouts and fluid losses. It can be really difficult to control it accurately. So we've got to acknowledge it is difficult, that hour-by-hour correction, because of the difficulties in maintaining the fluid in and out in these patients. I'll finish with IAS. So he was the guy that's done a lot of the seminal work, and to the Macmillan paper, the one from Canada, he wrote an editorial. He basically confirmed the development of osmotic demyelination syndrome is exceedingly rare and unrelated to rapid correction. Smaller studies have shown the same. Much attention's being paid to limiting the rates of correction, with treatment guidelines becoming progressively more restrictive. Strict adherence to these wonderful guidelines may result in insufficient therapy, frequent monitoring, needing to re-lower the sodium with desmopressin or whatever, or giving more sort of clear fluid, non-saline containing fluids, water, prolonged hospitalization. Some of these studies showed actually going slowly increase the length of stay and an increased cost without clinical benefit. More liberal guidelines are warranted to allow for acute elevations and with hypertonic saline to prevent neurological complications. So, Mr. Chairman, ladies and gentlemen, I rest my case. Thank you.